Hello, fellow classmates of Theoretical and Scientific Foundations of Advanced Nursing Practice. My name is Nicole Stombaugh, and I am going to be discussing the Transtheoretical Model of Change with you. The Transtheoretical Model of Change is also known as the TTM, and it was initially written by James O. Prochaska, PhD. James O. Prochaska was born in 1943. He is a professor of psychology and director of the Cancer Prevention Research Center at the University of Rhode Island. He is also the developer of the Transtheoretical Model of Behavioral Change. Prochaska earned his BA in psychology at Wayne State University in 1964, followed by his MA in 1967, and then his PhD in 1969. He is the author or co-author of over 250 publications on the dynamics of behavioral change, most of which defend the TTM. TTM is a model of intentional change. It is a model that focuses on the decision-making of the individual. This model is based on an individual's process of changing a positive or negative acquired behavior. It takes into account various independent variables and barriers that could affect the outcome of attempted change. The TTM is a model of intentional change that focuses on the decision-making abilities of the individual rather than the social and biological influences on behavior as other approaches have tried. TTM is also known as the stages of change, and it is arguably the dominant model of health behavior change, having received unprecedented research attention, yet it has simultaneously attracted criticism. The TTM evolved through studies examining the experiences of smokers who quit on their own with those requiring further treatment to understand why some people were capable of quitting on their own. It was determined that people quit smoking if they were ready to do so. Thus, TTM focuses on the decision-making of the individual and is a model of intentional change. The TTM operates on the assumption that people do not change behaviors quickly and decisively. Rather, change in behavior, especially habitual behavior, occurs continuously through a cyclical process. The TTM is not a theory but a model. Different behavioral theories and constructs can be applied to various stages of the model, where they may be most effective. The TTM states that individuals move through 6 stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and termination. Termination was not a part of the original model and is less often used in application of stages of change for health-related behaviors. For each stage of change, different intervention strategies are most effective at moving the person to the next stage of change and subsequently through the model to maintenance, the ideal stage of behavior. This model grew from systematic integration of more than 300 theories of psychotherapy, along with analysis of the leading theories of behavior change. The health behavior model, developed in the 1950s, was integrated into the TTM. The HBM suggests that a person's belief in a personal threat of an illness or disease, together with the person's belief in the effectiveness of the recommended health behavior or action, will predict the likelihood that the person will adopt the behavior. The theory of reasoned action, developed in the 1980s, now called the theory of planned behavior. This theory predicts an individual's intention to engage in a behavior at a specific time and place. The theory was intended to explain all behaviors over which people have the ability to exert self-control. The social learning theory in the 1960s. Learning occurs in a social context with a dynamic and reciprocal interaction of the person, environment, and behavior. The unique feature of the SCT is the emphasis on social influence and its emphasis on external and internal social reinforcement. SCT considers the unique way in which individuals acquire and maintain behavior, while also considering the social environment in which individuals perform behavior. The theory takes into account a person's past experiences, which factor into whether behavioral action will occur. These past experiences influence reinforcements, expectations, and expectancies, all of which shape whether a person will engage in a specific behavior and the reasons why a person engages in that behavior. This diagram shows Prochaska's stages of change from pre-contemplation to contemplation, preparation, action, and maintenance. Before the target behavior change occurs, the temporal dimension is conceptualized in terms of behavioral intention. After the behavior change has occurred, the temporal dimension is conceptualized in terms of duration of behavior. Now we'll begin to go into the definitions related to internal criticism. Adequacy, clarity, consistency. TTM adequately explains all stages of change from pre-contemplation to maintenance. Theories need to be fluid like the population and healthcare in general. Times change, people's behaviors change, and social norms change. As of right now, I do not believe that this theory needs an update. It meets the current needs and behavioral change. TTM is used in many areas, from addiction to weight loss to healthy living. It does account for the subject matter. TTM clearly states all components that are considered. Each phase is clearly described, as well as issues and expectations with each stage. TTM is clear and concise. It describes the 5 to 6 stages and also what the patient may be experiencing in each stage. The theory is consistent and it maintains the definitions of the key concepts throughout the explanation. For example, the key concepts of TTM do not change. The 5 to 6 stages are definite. It has congruent use of terms. The methods remain the same regardless of what is being studied. Continuing with internal criticism definitions, we'll discuss logical development and level of theory development. The theory is based on many different models and does follow the thought processes of the previous works. The conclusions proceed in a logical fashion, although there has been some criticism about the difference in the pre-contemplation and contemplation stages and the time frames involved. TTM is considered a middle-range theory. Middle-range theories are substantially specific and encompass a limited number of concepts and a limited aspect of the real world. They are composed of relatively concrete concepts that can be operationally defined and relatively concrete propositions that may be empirically tested. A middle-range theory may be 1. A description of a particular phenomenon, 2. An explanation of the relationship between phenomena, or 3. A prediction of the effect of one phenomenon on another. Moving on to external criticism definitions, we'll discuss complexity, discrimination, reality convergence on this slide. There are 6 main components in TTM and 10 other components that support the initial 6. TTM is straightforward and can be understood without lengthy descriptions, but is complicated by the fact that people often jump from stage to stage. TTM is a model of behaviors that individuals go through while attempting to modify a good or bad habit. TTM is unique to intentional change in behavior. Previous studies focused on other variables, while TTM focuses on stages of change. The stages and experiences are relevant, although the model assumes that individuals make coherent and logical plans in the decision-making process, and this is not necessarily true. As said above, humans don't always do things in logical order. Also, there is no definitive time frame for how much time is needed for each stage, or how long a person can remain in each stage. External criticism continued. We'll discuss pragmatic, scope, significance, and utility. TTM provides suggested strategies for public health interventions to address people at various stages of the decision-making process. This can result in interventions that are tailored. For example, a message or program component has been specifically created for a target population's level of knowledge and motivation, and effective. The TTM encourages an assessment of an individual's current stage of change and accounts for relapse in people's decision-making process. The range of phenomena in TTM is narrow. As mentioned before, it is considered a middle-range theory. TTM neither describes what nurses do, nor does it impact the way we carry out nursing interventions. However, it is useful when educating patients. TTM is already in use by nurses, specifically in educating patients with addictions. Some of the tools used for TTM. The tool used is the readiness to change ruler, which is a simple straight line drawn on a paper that represents a continuum from the left, which is not prepared to change, to the right, which is ready to change. Patients are asked to mark on the line their current position in the change process. Healthcare providers should then question patients about why they did not place the mark further to the left, which elicits motivational statements, and what it would take to move the line further to the right, which elicits perceived barriers. Healthcare providers can ask patients for suggestions about ways to overcome an identified barrier and actions that might be taken before the next visit. The tool is a wonderful addition into any healthcare field as it is cost-effective and useful. Another tool is the agenda setting chart. The healthcare provider draws multiple circles on a paper, filling in behavior changes that have been shown to affect the disease in question, and adding a few blank circles. The healthcare provider then opens with, "Let's spend a few minutes talking about some of the ways we can work together to improve your health. In the circles are some factors we can tackle to improve your health. Are there other factors that you know would be important to address that we should add to the blank circles?" The discussion then revolves around the patient's priority area and identifies a goal that might be achievable before the next office visit. The agenda setting chart is useful when multiple lifestyle changes are recommended for long-term disease management, for example, diabetes or the prevention of heart disease. There has been an overwhelming amount of research published based on TTM. I'll discuss two, one of which is a national sample of pre-action adults was provided a stress management intervention. At the 18-month follow-up, a significantly larger proportion of treatment group, 62%, was effectively managing their stress when compared to the control group. The intervention also produced statistically significant reductions in stress and depression and an increase in the use of stress management techniques when compared to the control group. In the next study, 1,277 overweight or moderately obese adults with a BMI between 25 and 39.9 were recruited nationally, primarily from large employers. Those randomly assigned to the treatment group received a stage-matched multiple behavior change guide and a series of tailored, individualized interventions for 3 health behaviors that are crucial to effective weight management: healthy eating, moderate exercise, and managing emotional distress without eating. Up to 3 tailored reports were delivered based on assessments conducted at 4 time points: at the baseline, 3, 6, and 9 months. All participants were followed up at 6, 12, and 24 months. Multiple imputation was used to estimate missing data. Generalized estimating equations were then used to examine differences between the treatment and the comparison group. Coaction of behavior change occurred and was much more pronounced in the treatment group, with the treatment group losing significantly more than the comparison group. This study demonstrates the ability of TTM-based tailored feedback to improve healthy eating, exercise, managing emotional distress, and weight on a population basis. The treatment produced the highest population impact to date on multiple health risk behaviors. My view on the current utility of TTM is that it is useful in research and is currently in use in practice. Current areas that TTM is used is drug and alcohol rehabilitation, smoking cessation, healthy eating, as well as promoting exercise regimens. Many types of research involving a person's commitment to change can be done based on the stages in TTM. Thank you, classmates, for taking the time to watch my presentation. I've learned a lot about TTM, and it is definitely an interesting model. Have a nice spring break.